You all should have just received notification that we are recording this session, so I remembered to hit the record button. That's always a good thing. I want to introduce myself. I'm Kathy Pabst, your Executive Director of the Missouri Academy of Family Physicians. Bill Plank is also joining us. He's our Assistant Executive Director. And we have been actively working with family medicine students and residents over the last several years. And this is one of the ideas. Noah Brown is on today's session, and this was his idea to present every springtime to students. So today we have Dr. Kara Mays with us. She's in St. Louis, and she's going to be talking about wellness and obesity management, which is what she specializes in as a family physician. And I'm going to go ahead and turn it over to Dr. Mays, who can provide more information about herself. So thank you.
Perfect. Thanks, Kathy. And thanks everyone for giving up just a little bit of your day to be here and learn more. I am, as Kathy said, a family physician in St. Louis, Missouri. A little bit of my background. So I'm a native St. Louisan. I went to undergrad at Mizzou and then came back to St. Louis for med school at St. Louis University. I then continued to stay in St. Louis and did my residency at Mercy Family Medicine residency here in St. Louis. When I finished residency, I actually initially joined our faculty straight out of residency and became faculty for the family medicine residency program. In doing that, I did kind of fairly traditional full spectrum family medicine. I did inpatient rounds, I did maternity care and deliveries, and then just typical outpatient clinic as well, along with lectures for residents and advising and other more faculty responsibilities. Over the first few years that I was in practice, I eventually started, we've all seen patients, even in medical school, we see patients that are struggling with their weight and have done so many things and tried so many different diet plans or exercise or sometimes even pretty extreme things, and people still struggle. I had a patient actually is how I started to get interested in obesity medicine, because I had a patient who came to me. I was probably only 2 or 3 years into practice, and my patient said, "Hey, I read about this new medicine for weight loss. What do you think? Would I qualify for this?" And I had not yet heard of this new medicine for weight loss. Sometimes we learn the most important things from our patients. So I looked into it. I tried to figure out, looked at the research studies for the approval, looked at all the information from the FDA, did what I could to find out whether or not it was safe and effective and whether or not my particular patient qualified. And it looked like she did. So I went ahead and prescribed her this medication, and we just kind of started that journey together. Once I had that patient have a lot of really good success in her weight loss that she hadn't seen in the past, I started to bring it up with more and more patients and got more and more comfortable with prescribing medications to help with weight loss, but also started to learn a lot more about what patients could do from a diet and exercise perspective. I started to learn about what some of the resources were in my area as far as dietitians and exercise physiologists and what there was out there, so that I wasn't doing it all on my own. But eventually I was not just seeing my own patients to help with their weight, but my partners and in the practice were sending me their patients to help with their weight loss journeys as well. So it became something that I was doing more and more of each year. It became the part of my clinic day that I would look forward to the most. If I knew I had 1 or 2 follow-ups for weight management appointments, I knew that they would be people that I'd get to focus on their health and wellness with, instead of just focusing on treating disease or diagnosing acute problems. And the more I did it, the more I loved it, and the more I wanted to know, the more I wanted to learn, because we don't learn a whole lot about weight management anywhere in our training, including in residency. So I did a lot of that on my own. And as I started to learn more, then I learned that there is actually a board exam for obesity medicine. It's not an officially recognized subspecialty by the American Board of Medical Specialties, or ABMS. There might be another S in there. I'm not totally sure, actually. But there is an American Board of Obesity Medicine who provides an exam so that people can say that they're certified and a diplomat of the American Board of Obesity Medicine. It does not require a fellowship, although there are now fellowships available in obesity medicine. So each year there's a few more across the country, and I think there's 15 to 20 at this point that are kind of optional one-year fellowships after residency training. But at the time, and another option that it still exists, is really just what they call the CME pathway for boards. So there's a required amount of obesity specific CME hours that I had to go through. It was like a conference and a half is what it ended up being that I went to, along with a lot of study and online courses to get the rest of those hours on my own, and simply to prepare for the board exam. But then it's ultimately applying for and sitting for this board exam that's really, as far as board exams go, probably the easiest one I've ever taken, compared to all of the USMLE or COMLEX and ABFM board exams were all much harder than the obesity medicine one, in my opinion anyway. So I kind of, kept growing, kept learning. And then 3 years ago, Mercy, which I was still working as faculty in the residency program, was talking about trying to open up a weight management specific clinic. And they wanted to be able to have this kind of embedded in the primary care department so that our primary care doctors whose patients really wanted extra help could figure out a way, could come to this weight management program and get additional help. Somehow I managed to find out that Mercy was working on this at the same time that I was working on getting my board certification, and was able to get connected to the right people and be the one to really start and lead this program. So back in, I guess it was 2018, we opened up what we call Mercy Weight and Wellness, which is our medical weight management program here at Mercy. And I'm the medical director for the program. It's really a great thing. It initially was just a couple days a month that I was spending time at weight management, and then became at least a half day every week, and then became a full day every week. And just this past fall, I actually decided to make this my full-time career. So I made the decision to leave primary care part of family medicine and transition to only doing the weight and wellness clinic. I think it's, it obviously was a hard decision. In primary care, I had so many families and patients that I was taking care of that I've known for a long time. And I've been in practice for about 10 years now. And even prior to that, I kept some of my continuity patients from residency. So some of these people I'd been seeing for 12, 13 years, and deciding to have to say bye in this way was really hard. But I knew that in order to really be successful at our weight management program, I needed to spend more time here. And at a certain point, if you're not in a primary care clinic enough days, it's not really feasible to take care of your patients. And, it's hard to be a primary care doctor in 1 day a week. Patients need you a little bit more than that. So I made this transition in October, and now my only job is obesity medicine, weight management. I work with a big team of people, which is another cool thing about weight management. So we have dietitians, we have an athletic trainer, nurse practitioners, and a couple other physicians. And we have a blast. We really get to celebrate successes with our patients. We get to get rid of insulin for people. We get to see better A1Cs. We get to take off blood pressure medicines. We often start our journey with patients giving them more medicines, but it's so much more fun when we get to the point where we're taking all these things away. And we also just get to see our patients feel so much better. Even about a 10% body weight loss, patients just feel great. They move better than they used to move, and they can, run around after their kids better, or be more active on vacations. I saw someone recently who was like, oh yeah, I went to Arizona on vacation and we went on a 6-mile hike, and I never would have been able to do that a year ago. And I think that's great. Like, that's what we're here for. We talk about weight, and we talk about BMI, and we talk about all these things, but really what matters for our patients is how they feel. They care about their weight, but it's not so much about weight as it is about their health and their happiness. And so that's why we named it this program Weight and Wellness in the first place, is because we didn't want it to only be about weight. But we know that that's a big part of people's lives as well. So we are really, I love this specialty of primary care, my subspecialty, which I think is important for people to know anyway in family medicine. I often have family medicine residents that rotate with me here for elective time, just to be more comfortable in managing obesity in their own patients. Because there will never be enough obesity medicine specialists to take care of every patient with obesity, just like there's not enough endocrinologists to take care of every patient with diabetes. And that's the joy and the value of primary care, is that we really do get to take care of everything. So I'm hoping that some of you guys have questions. I can talk more, but I think what's more interesting to me is to figure out what you're thinking, what questions you have about my path, about my career, about obesity medicine, about anything, really.
So Dr. Mays, thank you very much for providing that. You know, one of the things that as I was listening to you, what you're doing is keeping patients out of the doctor's office later in life with more chronic healthcare issues. You talked about the diabetes. So I'm thinking that is extremely beneficial to medical students as you all decide what kind of practice you're going to be in, and who knows what journey you're going to take and pathway you're going to take, similar to Dr. Mays. I don't think you set out to do weight management and wellness, but the journey took you there. So being open to opportunities like that, I think, is also very important.
Yeah, like I said, I think it's one of the cool things in family medicine is really the different ways that we can specialize if we want to. I thought for a while in medical school and into residency, I thought that I wanted to do a sports medicine fellowship when I was done with primary care. I'm a runner, so I've had a million, running overuse injuries in my lifetime. But I think there's so much similarity. Like, the reason I liked sports medicine is because I was taking care of patients who were there because they were being active and they wanted to get back to being active. And so while sometimes the cause of seeing patients with obesity is not that they were active, right? But they're there because they want to improve. And so it's kind of a similar outlook. But I think we're helping in an even bigger way. So now that I'm doing weight management, I see those similarities between these patients and the ones that I thought I wanted to help in sports med. But yeah, I definitely didn't see that in the initial part of things.
So any questions for Dr. Mays?
I had a quick question. Thank you, Dr. Mays, for the talk. It was I enjoy hearing about this because I love the the management of obesity. I think that's there's just so much that you can kind of do to help patients and so much you can talk with them about. So I appreciate your insight here. So I just had a quick question. So I know you kind of mentioned that Mercy has a program for this. Do the family medicine residents at Mercy get a lot of experience in your clinic, helping and learning about weight management?
Yeah, so until last year, I was actually still supervising the residents in their continuity clinic at least once a week as well. But that changed in addition this past October with all of my transitions that I had. But ultimately, there's nothing required. They do, though, I would say 2/3 of the residents, at least at Mercy, will come and do an elective month with me. where they spend the entire month really focused on obesity medicine. And they do more than just work with me. They work with our dietitians. They spend a couple of clinic days with one of our bariatric surgeons to kind of really see that part of weight management in depth as well. So they definitely get it, but it's still not required. And I've also had people come back and do a second month with me after they do one, because they realize how big of a deal this will be in their practice, because
Absolutely.
there's just so many patients that are having a hard time.
Absolutely.
Dr. Mace, I just wanted to ask if, I know GLP-1 agonists are often used in kind of the management. What strategies have you found for getting those covered? I know that is a barrier in a lot of these cases.
Yeah, that's the $1 million question, I think, and maybe not literally $1 million, but the $1,000 question, if we're working on coverage. We have a few different strategies, and honestly, it's sometimes trial and error because every plan is different and it's so hard to know which plan covers which. When there's a new diabetes drug on the market, like all of the plans cover it within a year, right? When there's a new anti-obesity med on the market, people think it's not as important. People making these decisions still think that obesity is not a medical problem and that people are just lazy, or they just need to stop eating fast food, or, and so many people that we see are eating really healthy, and are already working on exercise and being active and still aren't losing weight, because it's not just about the calories, right? And I think we all understand that, but I think a lot of people still don't really, like, on an underlying level, get that. So when the people making the decisions for all of these businesses, insurance plans, they get asked by all the big benefits companies, great, do you want to cover obesity medicines or not? And they're able to just say, nope, because it's an easy exclusion. People who work at Mercy don't get coverage for our weight loss medications. And I've had multiple talks over the last year or so with the people who make that decision here, to try to get that changed. But there's a lot of kind of bias and stigma against obesity treatment, just like there are so many things, right? So how do we get them covered? Number one, we try. So for the GLP-1s that are actually kind of FDA indicated for weight management for obesity, so that's Saxenda and Wegovy, which is just different brand names of Victoza and Ozempic. So both GLP-1s, both of the ones that are approved for obesity are at a higher dose than what we use for the treatment of diabetes. Theoretically, some patients never get to the higher doses just because of tolerability. So first off, we try to prescribe the ones that are for obesity when we can. I think even simply the act of getting those prior auths, even if they get denied, like I feel like we're maybe doing a little bit of good just by letting the insurance companies know that we want them. Probably not a lot, but maybe a little, right? And some people have coverage. The Missouri state employees have coverage. So there are a lot of places that do, but again, it's business by business. So it's not just Blue Cross covers it and Aetna doesn't. Every single plan can cover them if those employers opt in. Medicaid doesn't cover it, Medicare doesn't cover it, and I don't know how long it will be, but there are plenty of people working on lobbying CMS to try to get coverage for anti-obesity medication as well. So first we try the obesity ones. If that doesn't work, there are some plans that will cover the diabetes versions of GLP-1s for prediabetes or for insulin resistance or for PCOS. So we'll try that as well to try to get coverage for people. So we talk to them that we're technically using this off label because it's only approved for diabetes, and you don't have diabetes, but I still think this medicine can really help you. And so we'll do that as well. But then again, there are plans that say, no, sorry, we're only going to pay for this medicine if you have type 2 diabetes. So, and then we have nothing, because I think I've met one person that was willing to pay the $1,000 a month for a GLP-1 when it wasn't covered. And there's coupons to save $200, but that's great if it's covered and you're getting your copay cheaper. But you know, I think it's $900 versus $1,100 is not really enough of a coupon to make that work. So
Yeah, well, thank you for speaking to that.
yeah, absolutely. So for a lot of those patients, we just don't have an option of a GLP-1, and we, try for other things. We get a little bit of benefit, like with metformin for insulin resistance, but again, that's not a huge weight loss. It's just usually a little bit of a help. Sometimes combining that with phentermine or with the topiramate phentermine combo, all of which are a little bit more affordable than the GLP-1s, can be helpful as well.
So can you share a story about one of your biggest successes with your patients?
I love that question. We have successes all the time. Like, I just saw someone who used to be on 80 units of insulin a day, who now is not. He's not on any insulin. And his A1C is like in the pre-diabetic range. It like just phenomenal changes. And in those people, it's not just the insulin, it's giving themselves shots multiple times a day. And we get that to, usually we still have them on Ozempic or something where they're giving themselves a shot once a week. But that's a lot better for your lifestyle to have to deal with that once a week. Then, if we get rid of insulin, we're also getting rid of the hypoglycemia that they probably had at times. And that just allows them a little more flexibility with what they're doing on a day-to-day basis. We have people who never went on vacation because they weren't comfortable in airplane seats, who have gone on trips for the first time. We've had people who are like, oh, I get in the car and my stomach doesn't hit the steering wheel anymore. And that's a big deal every single day. There are so many things, but I think it's not even the big successes that stand out to me. It's not we have patients who've lost 100, 120, 150 pounds through our clinic, but, and that they're phenomenally happy. But sometimes it's these little things that really make a difference for people and that are even more fun to celebrate on a daily basis. Not every day. We have plenty of people who we're not celebrating with, and we're struggling. One of the people we don't have in this clinic that we really need is a behavioral health specialist. And so that's been on my wish list since we opened and has not yet been someone that I've been able to hire. But we do a lot of referrals for behavioral health, but there's a lot of stuff that goes into people's lives and backgrounds and how they feel about themselves. And, some people feel depressed because they're heavy, and then other people actually struggle a lot when they lose weight and realize that that didn't fix everything in their life. Because a lot of people, I think, blame their weight. They blame themselves for their weight, and then they blame their weight for everything going on bad with them. And it becomes sometimes this just continual cycle of just blame and not feeling good. And so sometimes we serve a little bit of that behavioral health role, but that's true. And I think any aspect of family medicine there's a lot of behavioral health and mental health involved in our day-to-day.
Do you find long-term success with your patients, and how do you manage that? Because losing weight is sometimes the easy part. Keeping it off is the hard part. I've been there several times myself. So
we talk about that every day. We talk about what the long-term, outlook is and what patients do and how they follow up. And, medications have to be longer term than I think people want them to be. So, we don't give someone insulin for a month and say, okay, your blood sugar's better, let's stop it, everything's going to be fine, right? they have to continue that until they've made big changes that will sustain that better blood sugar level. Same thing with weight. It's not none of this is a quick fix. The whole concept of, because phentermine is still only FDA approved for 12 weeks. We use it long-term here safely. Most obesity medicine specialists believe that that's acceptable and safe and effective. But like medicine doesn't work if you don't take it. So 12 weeks of phentermine is not going to give anyone long-term success. Yeah, they might lose 15 pounds over 3 months, but then what? And I tell people, I don't care what they weigh in a month. I care what they weigh in 5 years. Because that is much more important. If they come back and they haven't lost any weight for a month, we initially see our patients on a monthly basis here, either me or one of the nurse practitioners, and we kind of swap back and forth. But if they haven't lost weight, we have to get them to look at that as a win too, when they're not gaining, and that, not giving up when they're not successful is really the biggest thing, so that they're continuing in the same path instead of regaining everything and then being back where they started, which then is kind of another emotional and guilt-laden thing when you're there. We try to keep in touch with our patients kind of long-term for almost all of them. We spread out appointments every 6 months or every year, or we have people whose primary care docs are comfortable with the weight management side of things that will say, okay, great, you don't need to come see us, keep seeing your primary care doctor, but call us. If you regain more than 5 pounds, call us. Or we have a certain, we make everyone have kind of a weight on the scale or a certain point where if they get back up to this, then they know they call us, or they start logging food regularly again and see if they can kind of figure out what's going on before calling us. But that we want to get these people back in, and we want to help before they get to the point where they're giving up and gaining a whole lot back.
So we have a few minutes left. Can you talk about your subspecialty and your work and personal life balance and how all of that comes together for you?
Yeah, so I think I've gotten really lucky in this role that I'm in right now. But with obesity medicine, there's no nights, there's no weekends, there's no hospital rounds, there's no babies to deliver, which I was still doing up through December. It's really made my life a little more predictable, even just on a daily basis, and in family medicine, when I show up in the morning, I know what my schedule theoretically looks like, but there's people calling all day that may or may not need to get put there or helped or stop what I'm doing with clinic in order to answer a phone call, and, really trying to triage people. Whereas here, my schedule in the morning is almost always my schedule at the end of the day. I can look, like I have plans tonight actually, and I know that my last patient is scheduled at 4 o'clock, which is earlier than usual. But like, that's not going to change. No one's going to get added on at 4:30 or at 5, or, it makes things a little bit easier because there's not so much of that last minute emergency. We don't, I guess we could theoretically still have patients that show up on Friday afternoon at 4 p.m. having a heart attack, just like they can do in the family medicine clinic, but that happens less here than it does in primary care. I think the other thing that we've really been able to embrace at the weight management program is video visits. So I was quarantined for 2 weeks with my kids having COVID, and I just got to stay at home, but I still saw patients. Because I can see patients from home now, and there are some that doesn't work. There are some people that need to come in, but for weight management, most people, the video is just fine. So.
Thank you. Are there any other questions? I've been kind of asking some that have come to my mind through this session. So I'll give you all a second if you want to join on.
If I could, just real quick, Dr. Mays, I know you kind of mentioned earlier that there is now kind of that subspecialty kind of board exam that you can take to be certified in obesity medicine. So do you feel like over time, in the near future, that there's going to be a lot more like obesity management fellowships off of family medicine that can kind of get you more training in that?
I do. I think they'll keep growing. There's at least a few more new fellowships every year. Most of them are pretty small still, and most of them are at, relatively large academic centers that have, 5 obesity medicine physicians that are doing this, that have big integrated surgical medical programs. So I think it will grow. I think it will be a long time still before a fellowship is a required part of becoming specialized. And I also think there's a lot of people who do this as part of their primary care practice, that they've done the work, they got the board certification or not, and they still do it. Like, there's not that much that I think the certification is great for showing that you've had that training and knowledge, but it's rarely required for a lot of positions.
Gotcha. Thank you.
Yeah.
Any other questions?
If I may, just kind of any general tips for an aspiring, hopefully be a resident come July in family medicine, and kind of developing my skills in obesity management throughout residency and going forward into practice, kind of general advice for that.
Yeah, wherever you're at, find the people that are interested. There will be. I think there's more and more people that are interested in treating obesity as a chronic disease that it is. You'll have a faculty member or two at almost any residency that at least is interested. So the Obesity Medicine Association, the fee for students and residents to join is $25 a year. They've got, that comes with all kinds of free webinars and information. So that's been a great resource for me. And I've had a lot of the residents who've done electives with me join for that $25 so that they can access some of that education as well.
Thank you.
Yeah. And if you come to Mercy, then find me.
What was the name of that organization that you mentioned?
OMA. It's Obesity Medicine Association.
Perfect. Thank you.
Mm-hmm.
Very good. Excellent conversation and discussion. So thank you very much, Dr. Mays. We appreciate your time, and to all of our participants, we appreciate your time as well. Just as a reminder, our next session is March 23rd at noon, and it is going to be Kelly Doherty. She is a medical student who will hopefully be a resident in July as well. And she's going to talk about her journey to applying to different residencies. And her experience is as a couple with her and her husband. So hopefully you can join us for that session on March 23rd. Again, thank you all very much. We appreciate your time, and we hope you have a wonderful afternoon.
Thanks, everyone.